we're going to brush the teeth, right? We're going to simplify. We're going to realize what's most important, and we're going to make things simpler for us. We don't have to do all 4 of those things like they used to do. We're going to begin to limit these things because they can't do them anymore. Okay. Reduce decision-making demands. People with dementia really should not be asked to make a decision. They can't. And they don't know what the right answer is. And so they're anxious. Okay? So when we give choices, if we do give choices, it should be 2 only, right? And it should be very simple. I get this a lot with family members when they realize their loved one can no longer pick out their clothes. They tell me he stands in front of the closet for hours and can't quite figure out what to wear. So I will say, pick out 2 outfits, put them on the table or the bed, and ask them, what would you like to wear? They've got 2 choices. Very simple, right? If they've got 50 shirts in the closet, they can't make that decision. It's too overwhelming for them, and they feel anxious. So simplify things for them. Nonverbal activities. So these are things where we like, and we do this a lot. We don't even realize we do it, right? Like, again, setting the table. I could venture that if you handed Vince the placemats and didn't say a word, he would know exactly what to do with them, right? Because it's a routine. It's something he does with you every day. Sometimes we give them something, we offer a verbal cue, we're confusing them with what we're doing. If there are things that you know that they know how to do just because you've done them over and over again, don't feel the need to give them additional instruction on what to do. Does that make sense? And then focus on long-term memories, things that we know are, things that they've done previously that are very comfortable for them. We want them to feel successful. It's what we do here with the Montessori programming at Town Square. We figure out what their level is, and then we have them do tasks and activities that they can feel that they've achieved something. As human beings, even, some of us who are, or hopefully someday we'll be retired, but for those of you who are retired, you get up every morning, you still want to achieve something. You still have a goal of doing something during the day, because when you achieve something, you feel good about yourself. I don't care how little it is. Give the person that you live with, that you love, who has dementia, something that they can achieve so that they can feel good about themselves. Caregiver strategies. So again, some of these are we're kind of hitting them twice, but keep routines and caregiver consistency. This idea that, I can call the agency and they can send 100 different people in. Try to stick with the same caregivers. Try to stick with the same people doing the same caregiving, assisting for you. If you have one person who does the shower, try to make sure it's always that same person who does the shower. Because to you, it doesn't seem like a big deal that it's somebody new who's going to be doing it, but it's a big deal to your person with dementia. History and preferences. So people's history in terms of, what they like to do, what is their kind of go-to. We all know what those things are for our person, right? And a lot of times those are very soothing activities. I know sometimes it's a puzzle, right? They love to sit and do their puzzles, and we know that that's calming for them. Well, right now we want them to eat breakfast, but they're agitated. But we know that if they sit and work on their puzzle for a short period of time, it will de-escalate the situation. Let them work on the puzzle. Adjust. We have to shift in order to make them more comfortable. Personalized communication, right? We want to make sure we use words that they know and they're comfortable with, and in a way that we've always spoken to them. Manage the caregiver stress. Come to Caregiver Educational Series and learn all the more things you have to do in order to take care of your loved one. We all know that caregiver stress is enormous. We all know that you're doing the jobs when you're caring for a dementia patient who's late stage 4, early stage 5. Individually, you're doing 6 full-time jobs. 6 full-time jobs. Yep. Between housekeeping, managing the day-to-day activities of life, cooking, cleaning, managing medications, providing support. If that person was in a facility, it would take 6 full-time people to do what you are doing as a caregiver. The other thing that's really important to me, and I find that this was really interesting to me, was as a clinician, when I see a patient, I chart on them, right? I document. And then families come in and they go, well, we did this and it didn't work. And I go, no, because I wrote down, we tried this medication, this was the outcome. And then they go, oh yeah, that's right, that was what happened. We forget what works and doesn't work. Keep a notebook. If you try something and it works really well, write it down, document it, so that you have a resource for yourself of things that you can go back to and say, oh yeah, I forgot. I tried this and it worked really well. Let me try that again because what I'm trying isn't working. We're overwhelmed as caregivers, right? We got a lot on our plate. So to think that we're going to remember everything just isn't realistic. When to seek professional help. So if your person has always been sort of calm, doesn't really get agitated by much, and now all of a sudden everything is causing them to be irritable and agitated, their behavior is really changing. The delusions, the paranoia, the behaviors are really changing. This is when you really need to seek professional help. This can oftentimes be a medical issue. We all know, we talk about urinary tract infections and other types of infections. People can have shifts in their electrolytes. They can be dehydrated. There can be all types of medical reasons that are causing our loved one to have a sudden change in their behavior. So don't just chalk it up to, oh, it's their dementia. If it's different, very different from what you're experiencing, then that needs to be treated by a professional. Depression, anxiety, or withdrawal, again, I do psychiatry for a living, so it's kind of hard for me not to be biased. But the majority of the patients that have dementia live in a difficult world. That difficult world raises the cortisol levels in their body, burns out the receptors for their neurotransmitters. They're not depressed like younger people are when they get depressed. They're irritable, they're agitated, because they don't have the neurotransmitters in their brain that help mediate their mood and make them be a little bit more comfortable in their own skin. So they need to be treated for that anxiety and that depression with medication, and the appropriate medication, because it will make a huge difference in how they manage their surroundings and your caregiver stress. Safety concerns. So this is the one time I'm going to go back and say, because I just said don't reorient, right? We reorient when it comes to a safety issue. If they say, well, I'm going to take the keys and jump in the car and go to Publix, that's when you say, no, you're not driving anymore. Let me have the keys from you, right? Because that's a safety issue. If they tell you they're going to walk down to the neighborhood bank of mailboxes without their walker, you say no, and you intercede in a reorientation way. You're telling them that they can't do that. The only time you want to reorient a patient with dementia is when it's a safety concern, when there's an issue that they're going to hurt themselves if they do something that they cognitively don't understand is beyond their scope. And then we talked a little bit about caregiver burnout. All right, how did I do? Not bad, 45 minutes. Questions? Shoot. Mm-hmm. Yep. And so how do you redirect that? I mean, you have to say no. You have to say no. Well, so there's a couple of ways to do that, and that oftentimes happen, right? So she lives with you in your home, okay, and you know that this is an issue for her, that she likes to cook. It's only happened a couple of times when she's tried. Okay, so there's always that like support that we provide by standing by, right? So we call it, standby support. And a lot of times we do this. I talk to families a lot about showers because they'll tell me, oh, he goes into showers by himself. Then he shows up here and he doesn't really smell all that well. And I'm wondering, okay, so how much is he really, like, he's getting in there, they're turning the water on, but is he really showering? And so we talk to a lot of families about doing the standby support in the bathroom. Well, if he's in the shower, you just happen to be in the bathroom doing your morning and you're keeping an eyeball on him, and you might say, hey, this is new body wash. Why don't you try this one? Or you put the body wash on the sponge and you hand it to them, right? Like, you're not telling them you didn't wash yourself correctly. You're doing standby assist, right? So you're overseeing what they're doing. You're trying to help them still be in control of their environment, but you're not going to be afraid that she's going to leave the stove on if you're doing standby assist, right? Because redirecting her is different than reorienting her to say, no, no, you can't do that, Mom. Okay, you want to make the eggs? I'm going to help. I love helping you cook. I'm going to get the eggs out for you. And you remember how we used to cook together, Mom? I used to love learning how to cook from you. And you make it into an old memory, and it's a positive experience versus, nope, you can't make eggs. Do you see? It's a lot of reframing. It's how we reframe it. It's how we get them to see it. And we want them to not feel like we're telling them no, because that never goes well. Questions? Other questions?
Can you repeat that statement you made about
Terminal neurologic disorder?
yeah.
Okay. So how many of you realize that dementia is a terminal illness? Good. Right. So terminal, the definition of terminal means that it will end your life sooner than normal aging. Okay? When you have dementia, your brain is degrading. Whether it's vascular dementia, whether it's Alzheimer's dementia, whether it's Lewy body, whether it's Parkinson's, the brain of a person diagnosed with any of those types of dementia is dying at a faster rate than everybody else who's aging normally. Therefore, it is considered a terminal illness. It is neurologic because it affects our brain, which is our control center for our entire body. And people will say to me, well, he's really healthy, except he's got dementia. And I think to myself, your brain is dying. It's the control center for your whole body. You're not healthy if you have dementia. What you're saying is you don't have other comorbidities. You don't have high blood pressure, diabetes, or kidney failure, but you're not healthy. So dementia is a terminal neurologic illness. Now, some dementias will take you faster. Frontal temporal lobe dementia will take you much faster than Alzheimer's disease. Alzheimer's disease can last 20 years. Now remember, most often is not going to get diagnosed until they're stage 4 or stage 5, which means they've had the disease likely between 5 to 7 years. So a lot of people will say, well, he was diagnosed last year. And I'm like, well, I don't really care when he was diagnosed, right? What I want to know is, when did you all start seeing symptoms? Because that tells me that the disease probably was present at least 3, 4, 5 years prior to that happening. So it's a progressive terminal neurologic disorder that causes processing issues, causes difficulty in executive function, carrying out complex tasks, and will ultimately take the person's life. Will take them faster than normal aging, right? Yeah, yeah. And I mean, and that's where our shift has to be, right? That's where we really want quality of life, not quantity of life. We don't want, I mean, who of us here would want to be walking around not knowing who we are, not being able to control our bowel or bladder, not knowing who our loved ones are anymore? So if our blood sugar isn't in great control because we got to eat ice cream every time we got agitated, it's a shift. It really is. In our society, we are so indoctrinated into, you got to live as long as possible. You have to stay healthy, you have to exercise and eat right and manage all of your chronic illnesses. When you have dementia, all of that should go out the window. You should live for the moment because you don't have. I mean, we think about cancer patients. Would you tell a cancer patient not to? Yeah, I have a lot. Right, light one up. Exactly. Right. Yeah. Right. At that point, it's kind of like, we seem to be able to shift easier when we think about it. When we think about cancer, we don't shift quite as easily when we think about dementia, but it's still a terminal illness. Give them grace and give yourself grace and recognize that it's okay for you to not so tightly control their blood pressure or their cholesterol or their blood sugar anymore because they're living the best life that they can for however much time they have left. In terms of the donepezil and the memantine and those sorts of meds? Yeah, yeah, yeah. So, again, this is one of the hardest questions I get asked by families because these are two medications that either work exceptionally well or don't work at all. And the only way that we know is when we stop them. So my hope always is by the time they come to me, because I usually get them when they're in stage 5 and are having behavioral issues. I mean, that's my specialty is behavioral issues, right? I'm not diagnosing people. I'm not seeing people when they're younger. That's the neurologist's job, right? The neurologist is really there to go through the medical history, make sure there's nothing else going on that this could possibly do the imaging, do the blood marker tests to see if it's Alzheimer's, if it's Lewy body, if it's whatever, right? If they've done their job well, hopefully they're going to put your loved one on donepezil or memantine early. Now, they're relatively benign medications. They're relatively inexpensive now. They don't have a lot of side effects to them. So I tell family members, keep your loved one on them until they get to such a point that decline would be a positive thing. And that oftentimes is when they get to a point where they move into a community. Who wants to keep somebody alive after they've moved into a memory care community? The problem with these medications, and what I tell a lot of my families is, you stop the medication and you get one of two things happens. Absolutely nothing, and they stay exactly the same with their slow and steady decline, or all of a sudden you stop the medication and they rapidly decline. All of a sudden they don't even know how to pick up that fork and feed themselves, and it happens within a few weeks. They no longer recognize you. They stop walking. That's always a really hard one for family members, when all of a sudden their loved one no longer knows how to put one foot in front of the other and is now wheelchair bound. If that happens once you've stopped the medication and you decided to do that when they were still at home and you were still taking care of them, I can't get it back. It's not like I can say, okay, we'll put them right back on this and we'll get that cognitive ability back. It's gone. So it's a risk versus benefit effect. I don't know the answer. I don't have a crystal ball. I know that it may be helping. If it's not helping, at least it's not very expensive and it's not going to hurt them to stay on these medications. So I encourage families to make that decision once they've moved into a memory care, once they've gone on to hospice services. I mean, some people keep their loved ones home, all the way till the end, put them on hospice services. That's when we take them off, right? Because the reality of it is we're allowing them to decline as quickly as they can because they have no quality of life anymore.
Did you say you would take off the medication that they moved into mass?
Well, most people who live in a memory care community have very little quality of life. They're not with their loved ones anymore, correct? And so the idea is not to prolong somebody's life once they move into a memory care community. And so this is where we oftentimes, they've been on a statin for forever, or we're tightly controlling their blood pressure, their blood sugar. A lot of those meds we decide to discontinue when they move in, because we know that the move into memory care alone is going to cause them to decline. And the reason they're going to decline is, again, they don't have that cognitive reserve. We're taking them out of an environment that's their normal. We're moving them into a new environment in which now they're going to have to relearn the entire environment, and they have literally no reserve to do that. So what's going to happen? We take them off the meds. My hope is 2-3 months in, now we're talking hospice services, we're making them comfortable, and we've respected them and given them some grace and an ability to exit this life peacefully and not spend 2 or 3 years walking around a memory care unit, being incontinent of bowel and bladder and needing somebody to feed them and not being able to recognize their family members, because nobody wants that for their loved one. Nobody. It's a hard reality. It's a hard reality. You're welcome. Lewy body dementia is a dementia that's similar, that we oftentimes see with Parkinson's disease. It was named after the physician who found it. And on imaging, we can actually see the Lewy bodies in the brain. Very common with Parkinson's type dementia. And oftentimes the symptoms of it are agitation, hallucinations, delusions, and irritability. And so it can be a very, very difficult dementia to treat the behaviors that go along with. I tell people all the time, I don't treat dementia, I treat the behaviors that go along with the dementia, because there is really no treatment per se for the dementia, at least by the time they come to me. Yeah, so dementia is that big broad term, right? That talks about, just like if we said we had cancer, right? That's that big broad term. And then there are multiple different types of cancers. There's multiple different types of dementias. So the youngest person I ever saw was 41 when she was diagnosed. I think she had it sometimes since she was about 36. She had vascular dementia, and she had had a stroke when she was pregnant for her daughter. And after that stroke, she continued to have multiple infarcts in her brain, and that caused the progression of the vascular dementia. But that's the youngest person I've ever seen. The youngest person with Alzheimer's I've ever seen, typically in their 50s, was started somewhere in their 40s. Yeah. Yeah, that's a very good question. So the question was, does the person with dementia know that they have dementia? So when I do the stages of dementia, with many of you have heard me do that talk, we do talk about, stage 1 is normal aging. Stage 2 is really early signs. And with stage 2, the person who is losing their memory typically knows something is wrong, right? They try to compensate for it. I would talk to many of my families about this, that people that are particularly intelligent and have higher education oftentimes are able to compensate for that loss because they develop what we call compensatory strategies, right? And so they can fool people very often. By the time they get to stage 4 and 5, a lot of families will say, he's in denial. No, he's not in denial. His brain is broken. There's a term called anagnosia, which is where the person doesn't have the cognitive ability to understand that they don't have cognitive ability, right? That's why I say, don't try to explain, don't try to reason, don't ask the paralyzed man to get up and walk across the room. Their brain is broken, they can't process that information. Stage 3, stage 4, they still have the ability to understand. They'll fight you on it, and they may fluctuate. One day they need your help, the next day they don't need your help. Again, a lot of it is how we frame it, right? The first line is your primary care. You go to your primary care, I'm having trouble with my memory. They're going to do a battery of blood tests. They're going to make sure that there's no vitamin B12 deficiency, that your vitamin D is good, that, you're physically, they've ruled out everything from a medical standpoint. Now they're going to send you to the neurologist. The neurologist is going to do the imaging of your brain. They may send you for neurocognitive testing, depending on where you're at, right? And then put that all together and come up with your diagnosis. And then what most of my families complain about, and many of you have said this to me, is that then you get the diagnosis. Your mom's got Alzheimer's, pat you on the shoulder, here's some Aricept and Dementia, I'll see you in 6 months. And out the door you go. Good luck, right? I mean, you go to Moffitt Cancer Center and you have a skin cancer, and by the time you leave, you got a whole team that are working with you, right? You get dementia, and you get a little card that says, come back in 6 months. Crickets, exactly. Unless you come here. Thank you, Pat. Unless you come here. Where our sole goal is to teach you people and help you understand what you've got coming so that you can be proactive about helping your loved one and to give you that education and resources that you need. Good. You're welcome.
I was just going to say to them that, Dad, my mom passed away in September. My dad already had dementia going. That's how we picked up.
Mm-hmm.
But since my mom's passed away, I'm sole caregiver because I went to their house, just bringing my room, getting rid of stuff, getting ready,
Mm-hmm.
after probably a year, we'll be one of us. But, I ran into like ledgers, and he was documenting since 2021.
Yep.
Losing his memory.
Yeah.
He knew.
Yeah.
And he would question himself even in, it's like a diary basically.
Yeah.
Yeah.
My dad had vascular. Yeah. And he would do the same thing. He kept the calendar books, and he wrote down everything. And we used to always laugh. We thought it was kind of funny. He was an engineer. We always knew he was sort of anal about keeping track of everything. But as he progressed with his vascular dementia, we realized that was his compensatory strategy. That's how he figured out what he was supposed to do and when he was supposed to do it, because he was too proud to ask anybody for that information. And it wasn't until he could no longer manage that we really saw the decline. And I think that's very true of your dad. Mm-hmm. Right. Nope. Nope. Yeah. So that was late stage 3, early stage 4, right? And because they don't want to ask their children. They don't want their children to know these things are going on. Sometimes they don't even want their spouse to know these things are going on, right? So they're going to compensate any way they possibly can. And this is where, Doug is a very educated man and was able to use those compensatory strategies to his benefit. But that's when the family when I finally get to them and I finally explain to where they're at, and they're like, really? And then they look back and then they find the ledgers and they're like, oh yeah, you were right. But did he really, or was it that was when you really started to see it? Yep. Right. Yep. Yeah. Did you have a question? Oh yeah. I saw your hand up. Yeah. Yes. The anagnosia. Yeah. Agnosia. Yeah, agnosia. Agnosia is where you don't have the cognitive ability to understand that you don't have the cognitive ability. And it actually happens in other diseases. I mean, it can happen in other diseases, but we see it a lot in dementia. So typically, yeah, it begins to happen in late stage 4, early stage 5. That's when they no longer can reason, right? When they're stage 3 and beginning stage 4, you can still reason with them because they still have the ability to understand understand. Now, they may not like what you're saying, but this is the